Hey, Mark Testa here at Regenexx headquarters with Chief Medical Officer and Founder Dr. Chris Centeno. Today we want to talk about IV stem cell injections for pain. And are they legit? Do they work? Is this a good way to get stem cells into your body? And we're going to turn this over to the expert and answer your questions. So we'll start out here. If you have questions around conditions that you might have, let us know. Put them in the comments. We'll be glad to get to those. And we'll get started here right now. So we see this a lot. IV stem cells for everything now.
Yeah, we're seeing it more and more, and I think it's becoming more and more common because we have a lot of offices that are doing amniotic and umbilical cord tissue. Now, those have no live stem cells. So if you haven't read my blogs on that and all the research we've done, the research done by Cornell, the research done by UC Davis that shows that these are all dead tissues, they're not live. But we've got a lot of places using those that don't have any expertise about how to get them in the right spots. The simplest thing to do is just start an IV. Now, from the patient's perspective, that's also pretty simple too, right? You just take a needle, you find a vein, you put it in there, you tape it over, and you start a little IV bag and you're good to go. So the problem, though, is the reality is the research shows that 97% of those cells will end up in your lungs. That's called a pulmonary first pass effect. So that means that if you put mesenchymal stem cells in someone's veins, they get clogged up in and captured by and trapped into the lungs. So that's sort of the problem that we have. And the other problem that we have if you're getting IV stem cells for pain is that many of the places that we would treat, let's say your shoulder rotator cuff, your low back disc, your knee meniscus, they're all blood supply poor. So there's no way that a cell is going to get where it needs to go if I put it in IV. It's going to first get trapped in your lungs, but even if it somehow gets past your lungs or egresses out of the lungs, it's not going to get to some place that has no blood supply, because places that don't have no blood supply don't have any access IV. So it's kind of an interesting concept and one that doesn't make much common sense, but there's a lot of folks doing it because, hey, you got a credit card that clears, we're good to go.
Now it's interesting to me. I mean, I've seen some of the bone marrow aspirate, and I haven't seen fat. But is any of this stuff chunky? Does it have any potential to cause clots or other issues, embolisms?
It does, and there's other problems as well. So one of the things that many years ago, I was involved in the investigation of a death in Korea, and they were using IV mesenchymal stem cells that clumped, and the person had a fatal stroke right after the IV was started. We determined that the death was from the IV stem cells. So the funniest thing is, and it's not funny obviously, it's a tragic thing, is that this is one of the more dangerous way to place stem cells into someone's body. There's the other problem as well. If you're using someone else's stem cells, let's say umbilical cord blood, which again have no live mesenchymal stem cells, that's chiropractic scam. But if you're using that kind of thing, it needs to be HLA matched. So it's got to be matched to that person. So for instance, if you go get an umbilical cord blood transplant, if you've got pediatric cancer, that's HLA matched to the person. So the blood is HLA matched to the person, and they try to get that match as close as possible. What happens if you don't? You can get graft versus host disease. That can be anything from as minor as a skin rash to as major as your organ shutting down and you dying. So again, really big problems here that you've got to be careful of. And I know none of these clinics that HLA match the umbilical cord blood to the patient. So they're all risking graft versus host disease. And I think most of them don't have a clue that it even exists as a problem. The patients are getting side effects. Some of them are ending up in the ICU, and everyone's scratching their heads.
Right, and that graft versus host disease doesn't necessarily show up like the next day or a couple days later.
Yeah, it can be delayed. In addition to that, you've also got the problem of serious chronic issues after this, meaning sometimes it resolves, sometimes it doesn't resolve, and you can be everything from mildly sick to really, really sick in the ICU.
So we'll get to some questions, but this one's right on topic. Is there any attempt to regulate this, as IV stem cell therapy seems to be widely advertised?
Yeah, I think we're going to see some very, very big moves by the FDA here. We have heard of FDA criminal investigators that have been asking about multiple different clinic chains that are advertising IV stem cells. We saw Livion, the company that had a contaminated product. So again, you've got that whole other matrix to talk about, and that is Livion was a company selling umbilical cord blood that still does, that had a contaminated product. So once you take a bacterially contaminated thing and you put it in an IV, you've got huge problems. There was at least a dozen of those patients that ended up in the ICU. And so long story short here is that yes, the FDA is going to be cracking down on this, did crack down on Livion, has continued to send out letters and warning letters to the manufacturers of these umbilical cord products. But at the end of the day, it's like playing whack-a-mole. They shut this clinic down and that clinic pops up. So that's the regulatory problem that they have.
And if you get an infected IV, it's going to go everywhere, right? Give you systemic infection.
You're going to be really, really, really sick, really, really, really quick. And if you're a normal, healthy person, you'll just spend some time in the ICU and have a catheter placed into your heart and get 6 to 12 weeks of IV therapy. If you're not a normal, healthy person, you're dead. So it's amazing that of those 12 people, no one died, but there's a lot of people that got really, really sick, and a lot of people who also get that stuff injected into their spine who are maimed for life. They're never going to be fully whole again after those events. I know this because I'm the medical expert, I believe, on all 12 of those cases right now. So I've had a chance to look into those medical records, and it's a mess.
Wow. Wendell asks about small fiber neuropathy, if stem cell or something like what we do would be helpful.
Yeah, Wendell, I know there's lots of ads for neuropathy out there, and you can treat peripheral neuropathy with orthobiologics. Stem cells are probably overkill, meaning that you can treat individual nerves with platelet growth factors, and patients do pretty well with that. But that's a highly specific and highly skilled injection, meaning you have to inject directly around the nerves that are involved, and that's done under ultrasound guidance. It can't be done by a nurse practitioner or a physician's assistant in a chiropractor's office. That is a subspecialist injection, and one that there's probably only 100 U.S. physicians right now that are qualified to perform. So yes, it can be treated, but it's a very technically demanding procedure that needs to be done by a super specialist, not by a nurse in a chiro's office.
Lamas asks about, he says there's someone in Florida attempting to do CCJ work and says he can cure it, does some capsular ligament injections. Now, I know really you're the only person doing this right now.
Yeah, so you have to be careful with all of the CCJ stuff, and I've written a number of blogs on this. Traditional prolotherapy is generally done blind, so that's kind of where you stick the needle in and you go for landmarks, so you mark those out in the neck. And obviously in the CCJ, or the upper cervical spine, you've got other things up there that aren't present really in the lower cervical spine. One of those is the vertebral artery. So if you inject some of that stuff into someone's vertebral artery, they could die, so you can't do that. So that has to be done under imaging guidance to make sure that you don't get into the vertebral artery. Then you get into folks that are using some imaging guidance, but they're not actually getting into, for instance, the facet joints. They're just using the imaging guidance to go to landmarks. As an example, let's take the C0, C1 facet joint and those capsular ligaments. There are probably 100 U.S. physicians who have done more than 20 C0, C1 facet injections. That's it, 100 in the U.S. I don't know who this doctor is, but my guess is he's probably not one of those, because that's a high demand or high skill procedure. And then we get into the concept of the ligaments that hold the head on, like we treat in the PICL procedure. That would be alar, accessory, and transverse. And there's no way to reach those ligaments from the back. You've got to go from the front. So if he's doing injections from the back, he's not getting anywhere close to those ligaments. So my guess is he's doing a standard prolotherapy approach. There are some ligaments that you can reach back here. You need to use guidance, but those aren't the ligaments that hold the head on.
And so Lamas asks also, you're asking about what are the outcomes, and we can only talk about our outcomes.
For which?
CCJ.
Yeah, I mean, it depends on what's causing the problem. If what we're talking about are the ligaments that hold the head on, accessory, alar, transverse ligaments, then we've seen some very good life-changing outcomes there. I would say about 2/3 of the patients that we're treating are responding very well. Probably about 25% to 1/3 are unresponsive or minimally responsive to that procedure. Now that's pretty good, given that for the most part these patients respond to nothing, meaning there is no procedure they've ever had that has really done much for them. So that's generally what's happening with that procedure, but that's a very, very different procedure. That's we're the only place on earth that does that right now. And you can't inject those ligaments from the back.
Johanna hears about people, particularly with Lyme or other active viruses, having side effects from PRP or stem cell or prolo, and wonder if you know much about this or what might be causing some of these.
Yeah, Joanna, I'd probably need to know more about what side effects you're speaking of. What we tend to do for patients who have known Lyme is we'll add in microgram doses of doxycycline into, for instance, the PRP solution or the bone marrow concentrate solution, meaning that that's a known Lyme antibiotic. We know it's tissue safe. We've been using it now for 13 years. And so that's generally what we'll do to try to inhibit any active transmission of the Lyme pathogens within the injectate. So I'm not quite sure, though, specifically what types of side effects you're discussing.
And so, as well, from her, would be being diagnosed with vertebrobasilar dilico VBD. Do you know what that is?
I have to see it written.
Dilicostasia.
Yeah, I'm not gonna have to. I can't read it.
Yeah.
Sorry,
okay.
Joanna, I can't read it on Mark's small screen here.
Right. Dilicoectasia.
So vertebrobasilar. So Joanna, what's your question?
Yeah, ask that again. If being diagnosed with VBD is a contraindication for receiving CCJ or PICL.
Yeah, I mean, we see changes in the vertebrobasilar system in many of the patients who are diagnosed with alar transverse ligament issues, meaning, as an example, if you go through Scott Rose's clinic in New York and David Harshfield reads your MRI, that's a common diagnosis that David will make, in addition to changes in upper cervical ligaments like the posterior atlanto-occipital membrane, the tectorial membrane, the alar accessory ligament complex, the transverse ligament complex, etc. So no, those are not contraindications for this type of procedure.
Stacy had 2 PICL procedures, which are helping, still having some symptoms. Can't get back to Colorado until June. Any point in going to Regenexx in Sarasota for PRP before June, or only more PICL in June? What would help?
Stacy, hard to say. If you have had in the past good temporary responses to posterior injections like upper cervical facet injections, ligament injections that are done from the back, then you might consider getting a touch-up PRP injection done down in Florida. If you haven't had much help from those injections, then probably just continuing on with the third PICL. Generally, what we're seeing is the average number of procedures is somewhere between 2 and 4, with most people getting 3 or 4. So that's generally what we're seeing right now.
Donnie asks, the Australia docs using your systems are not treating any bulging herniated discs. Can you elaborate on why? Is the effectiveness not ready for prime time?
Yeah, no, I mean, the doctor we have down there in Australia is a sports medicine physician that does only limited spine. So again, we qualify our physicians based on what their expertise is. So in the U.S., we would have, of our 70 sites, for example, about 45 to 50 that do spine work and advanced spine work. Regrettably, the site in Australia does not do advanced spine work right now.
Jack asks about torticollis and spasticity, if we've seen any improvements with that condition. Yeah,
when it comes to true torticollis, where the head is chronically turned and doesn't move and it's fixed, that's not something I think you're going to get much help from these procedures with. Now, when it comes to tight muscles that could be due, for instance, to upper cervical instability at C1, C2, then obviously treating the C1, C2 level can have an impact on things like the sternocleidomastoid muscles. So, but if it's a true fixed torticollis, meaning your head's chronically turned to the right and won't stop turning to the right, then no, this is not the procedure for you.
Carol asks, what percentage of IV stem cells will make it to an arthritic joint, to a knee?
Yeah, so it's a very good question. 97% would get trapped into the lungs, and then the remaining 3% would get distributed to lots of different places. So as an example, how many would get to the knee? Just looking at all of that, probably less than 1/10 to 2/10 of 1%. And then from there, if you look at different places in the knee, like how many would get into the most of the meniscus, none, or very close to none. So that's the problem. Same thing with the cartilage. The cartilage is also avascular, so you're not going to get anything into the cartilage. So that's the problem with this whole IV stem cell concept. It's done for the doctor's convenience, but not your health, meaning that it's convenient for the doctor, but it's definitely not the way to go if you've got a specific orthopedic problem.
Yeah, doesn't sound like spine, right? Disc doesn't have great blood supply.
Yeah, so most of the disc is not going to get any cells at all because it's got no blood supply. The disc actually gets its nutrition by imbibition, which is getting pushed on like a sponge and absorbing the nutrients through the end plates.
Jack asks if people get chiropractic manipulation during some of these treatments. Now, I'm not sure what treatments you're asking about, but certainly.
Yeah, so we have very few prohibitions on chiropractic treatment. So for instance, if you're talking about upper cervical instability and a patient has gotten good temporary relief from upper cervical chiropractic, we want them to go back and continue to get adjusted. Or if you're talking about someone that gets good temporary relief from their back pain or SI joint pain by getting it manipulated, not a contraindication, and usually we want them to return to that type of care as soon as they can.
And Johanna asks again, she's had bad results with AO and NUCA treatments. The reason's unknown, assumptions being that she's too unstable to tolerate. and she just wants to make a good decision about doing this or doing something else about it and is concerned about making things worse.
Yeah, so if you have not had, so Joanna, our upper cervical instability patients, I would say probably 25% of them have not had good experience with upper cervical adjustments. So we don't recommend that they get those at all. It's just for whatever reason it did not work for them. So in this case we would not ask you to do that. It's only those patients who really swear by it and who really feel like it changes their life in a positive way. And in those patients, we generally see their ability to hold on to an adjustment go up. So many of them come in only lasting, hours to days. And I just spoke to one the other day. She's up to 2 months now off a single adjustment. So, but we would not ask you to get those if they don't work for you.
Lamas, thanks for clearing up AO, Atlas orthogonal, form of chiropractic treatment for the upper cervicals.
Yeah.
Randy is going to see Dr. Cranberg in Wayne, going to get a PRP, but is wondering what your thinking is about testosterone replacement therapy with this treatment. His a little low. Would it be beneficial?
Yeah, so we looked at that pretty extensively with stem cell treatments. And this was back in probably 7 or 8 years ago. What we did was to take patients who had never been on testosterone and thyroid replacement. These were middle-aged males who had andropause, meaning low testosterone levels. We took those patients, we took bone marrow before we did it. We put them on a 3-month program. We took bone marrow after. We did not see any positive benefits from it with regard to their stem cells. But at the same time, we didn't really see much to be concerned about either. So with regard to a PRP injection in your knee, it shouldn't have any effects, positive or negative in all likelihood.
Right. And I want to encourage you, because a lot of people are seeing these ads for IV stem cells and things. If you know somebody who's considering some of this or has musculoskeletal pain or they're looking for other solutions, please share this with them so that they can find out, the truth from somebody who's been doing this longer than anyone in the United States and make an informed decision. Share this Facebook Live with them so they're informed. Let's see here. You mentioned first pass through the lungs. So how does that happen? What happens? How do they get trapped in there? Can you explain more about that?
Yeah, now realize what I'm talking about is real stem cell therapy. So regrettably, 95% of what's out there is not stem cell therapy. But if you actually have real mesenchymal stem cells, they tend to be about 10 to 14 microns in size. So they're bigger than red blood cells, and they literally are likely just getting trapped in the capillaries. They're just too big, so they're getting trapped. So that's I think the problem that's been discussed. Now, some of them will egress out of the lungs at a later date, but realize that if you've got a lung problem, IV is a great way to get stem cells. If you've got a knee problem, it's probably not the way to go.
Jack asks about if we've noticed any changes in bone spurs after a procedure.
Yeah, so Jack, you have to realize what a bone spur is. So a bone spur is your body's response to instability. So I put them into 2 categories. Functional bone spurs that are supposed to be there, they're actually helping the joint, and bone spurs that are hurting the patient. Now, probably 95% of all bone spurs out there are actually helping the patient. Excuse me, they're helping the joint be stable. So removing them is a bad idea. And only about 5% are causing any sorts of problems. So when they're causing problems, sometimes removing them can help. That's a surgical thing, or we also do a procedure that's non-surgical to remove bone spurs. But 95% of the time, they need to be there in order to stabilize the joint. So we don't take them off, or we don't deal with that at all. We work on stabilizing the joint by getting the ligaments to tighten down. And some of them will regress over time. if that's the case. But in older patients, many times they'll stay put.
All right. Lamas asks if there's more, if there's a greater benefit, more healing power with cultured cells versus a same-day procedure.
It just depends on what we're treating. So if we're looking at moderate to moderate severe hip osteoarthritis, cultured cells is the way to go. There's a big difference between the two. If we're looking at the average knee osteoarthritis patient, there's not as big a difference, only really a 10 to 15% difference. So if you look at those two things, you can see the spectrum of small differences but big increases in cost versus major differences. And so it just depends on what we're treating. So listen, as I always tell patients, if cost is not in the equation, and we do have some patients for whom the kind of money we're talking about for these procedures is within the disposable income range. These are people that would spend $30,000 on a weekend at a fancy hotel. Then by all means, culture has advantages. We can save cells for future use. We can go ahead and grow many more cells. But if cost is in the equation for 95% of the patients we see, then you really have to look whether or not culture cells are absolutely necessary to get the results. And for 90% of the people we see, it's not necessary. It's more of a luxury.
All right. Johanna, a question again about, she's read about viral reactivation in some after a stem cell treatment. Now this has been SVF. And if we have any concerns with our treatments for people with low immune function.
Viral reactivation of what?
Well, she's the one who asked about Lyme. Or
not a virus.
No.
Yeah, so again, I don't know of any publications on stromal fraction in this. I think we're probably hearing more anecdotal case reports. Realize that a lot of these, and I think probably what Joanna's talking about is there was a clinic in Beverly Hills that was called Infusio that was doing some stromal fraction treatments. So then we got to back that up to whether or not Infusio had any clue of what they were doing with regard to creating stromal fraction. So one of the ways, as an example, you create stromal fraction, which is currently illegal. It's not allowed to be done in the United States, but many clinics like Infusio were breaking the law and doing it. But one of the ways that you do that is you break down fat using collagenase. Now, collagenase is a pretty harmful enzyme. You can purchase it, and if you were to put collagenase into a joint, for instance, it would dissolve the joint. It's nasty stuff. So if you use collagenase to break down fat to get the stem cells out, to create stromal fraction, if you don't get all the collagenase out, that by itself could cause lots and lots of problems if you put that into someone's body IV. So if we're talking about what happened in Infusio, I don't have any idea whether or not the folks at Infusio had the first clue how to create stromal fraction for real, and whether or not that might have caused all sorts of problems in lots of different patients, and whether that has anything to do with whether stromal fraction will reactivate a dormant virus. We're 5 steps away from ever figuring that out.
Yeah, sounds like way too many confounding factors involved in that.
Yeah, I mean, again, you have to be extraordinarily careful in dealing with clinics that claim, like these clinics in Mexico that claim that they're giving you mesenchymal stem cells. Who regulates that? How do you know? How do you know they have any idea how to isolate mesenchymal stem cells, how to grow mesenchymal stem cells? What have they published? Have they published their flow cytometry data to make sure they're actually giving you mesenchymal stem cells? There's not a book for this. There's not a little kit that you buy and you do this and it creates mesenchymal stem cells. That's a lab process that's got to be validated and published on, and someone's got to go and make sure that what's coming out of the process is really mesenchymal stem cells. You wouldn't catch me dead at any one of these Mexican clinics that claims they're giving someone mesenchymal stem cells. I mean, that's a very, very hard process. It takes a year even to train a lab tech how to do that stuff and do it reliably and do it well.
So if it sounds too good to be true.
It probably is. That's what my mama used to say, so that's probably what's happening. $2,000 stem cells in Mexico? Yeah, you wouldn't catch me dead down there for $2,000.
Yeah. Have you done any work with any of the soft tissues that hold the hyoid bone together in place?
Yeah, those are the strap muscles, and they tend to get overloaded in patients that have TMJ or upper cervical problems, meaning that what tends to happen there is people tend to use these front muscles here called the strap muscles, and the hyoid bone is embedded in those. And so once those get overloaded, obviously that can cause tendinopathy in those strap muscles. Again, it's high real estate area because you've got lots and lots of blood vessels going through there. Those injections can be done under ultrasound guidance safely by someone who has a lot of technical expertise. Again, now we're down to maybe 50 US physicians that would have any sense of how to inject those areas safely. So many of the things we're talking about today require high levels of expertise and are technically demanding procedures that are done by anywhere from 50 to a couple hundred US physicians, and that's it.
And a great question by Ahmad on the same topic, really. How risky is the C1-2 facet injection? He's heard that it can cause issues with breathing and told never to have it done.
Yeah, Ahmad, any cervical injection where anesthetic is injected, or even a lumbar injection done poorly for that matter, can cause what's called a high spinal. So a high spinal is when you inject anesthetic inside the dura, or the covering of the spinal cord or nerve roots, and that causes the breathing center to be numbed out. Now, getting a high spinal is not a big deal in a clinic or a hospital setting or an ambulatory surgery center or an OR where they are prepared for that, meaning that if everyone's prepared for something like that to happen, you support the patient's breathing until the numbness stuff wears off and the patient's fine. The big problem happens is that when a high spinal is done in an inappropriate setting, where you get a high spinal in an inappropriate setting, in which case that's a big problem. That's a bad day for everybody. Meaning that you get a high spinal in a chiropractic office and the closest person that knows what to do is 911, you had better pray the ambulance gets there real quick, maybe hopefully across the street eating at McDonald's or something, because otherwise that patient's dead. So that's any cervical injection, not just a C1-2 injection. C1-2 injections don't have any higher incidence of high spinals when done correctly. We've done actually I just pulled this data. We've done 2,000 C0, C1s and C1, C2 injections. And that's only since we've had our EMR, so I'd say that goes back to about 2014 or so. So 2,000 in the last 5 years. There's not been a single high spinal in any of those. So again, not a problem when someone knows how to perform that procedure. But again, I think what you're hearing there is, again, the number of physicians who have done more than 20 C1, C2 injections in the United States is probably 100. So if you're with one of those 100 physicians, they would be very comfortable doing those. If you happen not to go to one of those 20 physicians, you're going to hear exactly what you heard because that's something that they haven't done and they have no experience in. And that's not only C1, C2, that would be any procedure any doctor doesn't know how to do. So that's what you get.
And we know these numbers very accurately, not only from your EMR, what you do, but with the core skills checklists of people who want to become a Regenexx provider, right? When you look at those.
We do. Now, again, in our network, in our Regenexx network, we probably only have, again, 3 or 4 doctors that I would refer to do high upper cervical work. Now, that's different than cervical work. We have many, many doctors that do very, very good C2 through C7 cervical work, that are very experienced doing that. That's probably 40 doctors in our network. But when it comes to high upper cervical work, C0, C1, and C1, C2, that's a specialized area. And you've got to find and really look hard to find doctors that have done those procedures and feel comfortable doing them. It's like anything else, whether it's being an auto mechanic or a motorcycle mechanic or a physician. Repetition breeds competency. Repetition in anything breeds competency, including this.
Yes, so true. Stem cell patches by LifeWave. Precious asked this. Have you heard of the stem cell patches by LifeWave? She's heard that they activate your stem cells to a younger state. And will they affect what we do?
Yeah, I think the likelihood that you really need to go do some research on LifeWave. I did this, it was maybe 8 months ago. Someone asked about this. I did some research on the company. This is a multi-level marketing scheme that goes way, way, way back. I tried to look at some of their research, which they claimed was really good, but it wasn't. And long story short is, I think there's no evidence that LifeWave activates your stem cells. And I think it's unlikely that LifeWave would activate your stem cells. I think it is just fine if you want to use a LifeWave patch with any of these any of these procedures. But you need to do some research on the company, because if you really research it deep past page 3, 4, and 5 of Google like I did, it's been around forever, and all sorts of issues have come up with this company.
Yeah. Let's see here. What's the best way to determine if the clinic is trustworthy or not?
Yeah, go and look at that stem cell little book I put out on the 5 things to look for in a stem cell clinic. That's on the blog right now. But basically it came down to a couple of different things. Number one is, these are MD level procedures. These are not procedures that can be done safely and competently by physician's assistants and nurses. So number one, you got to be looking for a doctor. And then number two is that doctor has got to have some specific training. So for orthopedic procedures, a good place to look is the Interventional Orthopedics Foundation, or IOF. Those are physicians who have gone through additional training and how to do these types of procedures. Then number 3 is make sure the doctor puts this stuff in with imaging guidance. So they're using ultrasound, x-ray, or both. So those are the kinds of things that I would look for if I were looking, let's say for a family member. Then you got to make sure they're actually using stem cells. So if someone tries to state that they're using umbilical cord stem cells, run. I mean, that's your first tip, that they don't have a clue what they're talking about. Meaning they didn't get the memo that umbilical cord products don't have any active and live mesenchymal stem cells. They're not reading the research on that. What they are doing is trusting what a sales rep told them in order to sell them a $1,000 vial of stuff that has a real value of about $30. So those are the kinds of things that I would look for if a family member came and said, "Hey, Chris, what do you think about seeing this guy in New Jersey?" Those are the things I would look for to vet that clinic, and I wrote a little book on that. It's 11 pages, and it's on the website.
Great resource, Regenexx.com. Daniel asks about expanding into Canada, and do we have any Canadian doctors that are going through the fellowship program?
Not through the fellowship program. If you go through interventionalorthopedicsfoundation.org, or I think it's interventionalorthopedics.org, sorry about that, IOF does have Canadian doctors that have taken the courses. Now, Canadians have another problem right now, and that is that Health Canada has decided that bone marrow concentrate and all stem cell procedures are not legal. So there are 1 or 2 Canadian clinics that I know of that are working with Health Canada to try to get that ban lifted, because it's pretty crazy. But Canada right now has kind of turned itself into an orthobiologics wasteland. But there are some really good doctors up there trying to do good work, and I would contact the Interventional Orthopedics Foundation to get their list of Canadian doctors who have taken courses.
Ahmad asks, what's the best way to determine upper cervical instability? Would it be with digital motion x-ray?
Yeah, Ma, there's lots of different things to look at there. In fact, I've got a blog coming out tomorrow on the Centeno Schultz blog site. So if you check that in the morning, it goes through all of that. It's actually for some patients that were on the Q&A Regenexx group on Facebook that were asking questions about this. I mean, there's lots of different static angle-based measurements that you can use. Grab Oakes, Powers ratio, clavoaxial angle, CXA, and then there's dynamic stuff that you can use like DMX or upright movement-based MRI. Of all of those, DMX is a nice technology because it's movement-based. Realize that CCI means craniocervical instability. So it's not a static concept. It's a movement-based concept, meaning things are unstable when the patient's moving. That's where the instability part comes from. It's not craniocervical, my angles are bad. It's craniocervical instability. So movement-based imaging is the way to go, like DMX. The problem is that most physicians don't really understand movement-based imaging. It's newer. It's not as well established. So they tend not to really understand it very well. So if you had to do one of those, I'd say a DMX is a nice one to do, or an upright MRI with movement is another good way to go. The problem is if you have side-to-side instability, that's harder to pick up on an MRI and easier to pick up on a DMX. And then you've got the static, what I call the angle, the dangle, and the squiggle, the wiggle measurements, and they're out there, and some of them are well validated, but they're all static. So they can be wrong in predicting whether or not someone's got craniocervical instability because there is no movement involved in those measurements.
Gabby asks, last time we spoke about a technique that you were working on to reduce the risk of disc infection during intradiscal injections. Have we been doing that, and does it have any negative side effects with stem cells?
Yeah, Gabby, so we worked with Greg Lutz at Hospital for Special Surgery, and our team and his team got together. Greg actually works with another company called Orthobond, which has nothing to do with this, but they're experts in looking at how to kill bugs. And the bug that we were interested in here was P. acnes. P. acnes is a bug that lives inside discs. And we don't know why it lives inside some people's discs, but it does. Probably about 20% of the population has this bug living in their disc. And you go in and you inject the disc and you stir it up, like stirring up a hornet's nest. And every once in a while, about 1 in 200 injections, that patient can get what's called discitis, usually from P. acne. So we looked at different ways to kill P. acne, and we came up with a recipe that was reliably killing it, including a very high concentration of leukocyte-rich PRP and a low dose of a very powerful antibiotic called gentamicin. And we've been using that, and we just started using it. So the lab test seemed to show that it's very effective at killing P. acnes. Only time will tell, because this is a rare complication of injecting a disc, meaning it's 1 in 200, whether or not that all pans out in patients. But the answer is yes, it can be used with stem cells. And we did that research, and we were very glad to see that there is a recipe. Now realize you can't make that recipe with the machines that are out there. That's a lab-only recipe. So if you're talking about someone that's got a bedside PRP machine, they're not going to be able to make this. But we can make it in the lab.
That's great. Stacy wanted to know if she calls a call center or calls Broomfield, can we tell her who in the network can do a C1-2 posterior injection?
Yeah, and I'll tell you the people off the top of my head. We've got a guy in Seattle, Jason Adaman, who's an extremely experienced high-level spine guy. We've got a Dr. Amoroso, who's down in Tampa. I think he's also still doing some work in the New Jersey area, who can do that type of highly complex spine work. Those are the two guys off my head who I've worked with to do those injection procedures. And again, it's one thing to be able to do it, or to say that you can do it, but another thing to say that you've done enough of them that you're competent, that you feel really good about it. And those are doctors, just again off the top of my head, who I would recommend. So for that kind of highly specialized knowledge, you probably need to come to me directly and send an email to me directly on that, so I can handpick some people, because the call center is not going to have a sense of that. That's a highly specialized procedure, and like I said, done competently by maybe 100 U.S. physicians.
And we've had this question in the past. It's a great question. How long after a stem cell procedure do they keep working? Yeah,
so given the research that's out there, it's all over the map. The biggest problem with the research that's out there is that most of it done in animals, where you can easily measure this stuff, is done with someone else's stem cells. And we now know that the research is starting to show us that when you use someone else's stem cells, they eventually get taken out by the killer T system in the host. The body does recognize them eventually as foreign. So all of those studies with someone else's stem cells now get thrown out the window. If you look at your own stem cells, then there's some pretty good research that those cells engraft and stay around long term. So that's what I would say currently based on the research that's out there. But to give you an example of how hard this problem is, we looked at tracking stem cells via a tracking agent in an MRI. So, kind of a funny story. I read this article, this is about 10 years ago. It said you could track stem cells. You put this kind of tracker agent that's commercially available into the cells, and you take an MRI. What the fine print, however, said was that you basically put the animal in the MRI all night, meaning that, if the amount of time it takes to a regular MRI is 30 minutes, this was 30 hours in order to get this signal. So that's some of the difficulty that we face in trying to track stem cells in humans. It's not easy to do, and that's why you tend to see these studies done in animals, because no one is going to sit in an MRI for even 10 hours, let alone 30 hours.
Let's see. I don't know if you have any idea. What is the average total nucleated count observed with patients?
Yeah, our mean TNCC, so let's explain that for people so people have some idea of what's being asked. So in bone marrow concentrate, as with other things, you have a total number of cells within the sample. Now that total number of cells within the sample is tied directly to, in general, the number of stem cells that are also in the sample. Because in bone marrow concentrate, there's lots of different kinds of cells. So that's called the TNCC, or total nucleated cell count. Our TNCCs on average run about in the 800 million range, or mean. That goes as low as 300 all the way up to 2 billion. And that's approximately where we are. I could get the actual number from the lab, but they're gone. But last time I looked at it, that's approximately where we are. So that's high dose bone marrow concentrate. The average TNCC that we see out there, for the most part, 99% of the places don't measure it. But when it is measured, it's probably about 200 to 400 million. So we're generally about 2x or more above where everyone else is. And that can go all the way up to 10x, depending on what it is we're trying to treat.
Joanne, glad to hear that you saw Dr. Sloan and your knees are doing great 3 years later.
Yeah, well, it's always great. Joanne, if you could, my email address is centenooffice@centenoschultz.com, and send me your story. I'd love to blog on those. It's really good to hear about long-term outcomes. A lot of times we lose track of patients because they move on with their lives and they're doing other things. But it's always great, and I would really have you write in to Dr. Sloan about that and say, hey, I just want to let you know 3 years out, I'm doing great, here's what I'm doing. Because that really makes a physician's day to hear that kind of stuff. That's why you do what you do.
All right. Let's see. Ahmad asks, one, if we know Dr. Nabidi. You know Dr. Nabidi? He did PRP to C2 through 6, but referred him to come see you for COC through C2.
Yeah. Happy to see you for those injections. Like I said, I just had our office manager pull it because I was curious. We did 2,000 in the last 5 years, so quite a few.
Right on. That's great. Joanne, thanks for spreading the word every chance you get. Let's see here. I just want to, one last time, if you know somebody who's dealing with musculoskeletal pain, arthritis, joint pain, rotator cuff tears, ACLs, somebody you work with, somebody who's talked to you about an IV stem cell, all too good to be true, please share this with them so they can find out the truth and the facts about how this stuff works and learn if it is too good to be true, because it really sounds like it is. Let's see. I think that wraps up a lot of our questions. Any final words before we wrap it up today?
Yeah, again, I think the big thing is just to realize that intravenous stem cells sounds really great. All you do is get an IV started like someone's taking blood, but it really is the most dangerous way that we have to deliver any experimental or investigational therapy, including stem cells, meaning that those cells can go any place and they can do anything. In addition, if you're getting any kind of umbilical cord blood, that needs to be HLA matched. That means that someone needs to test the markers that are on the umbilical cord cells and the markers that are on your cells to make sure that those are matched up. Otherwise, you can get graft versus host disease. At the end of the day, just be careful out there. Do your homework. I wouldn't send my dog to 95% of the clinics that are out there doing this stuff right now, simply because it's just a total Wild West mess out there. So just be very, very careful and do your homework.
Great. Well, thanks very much. That was a great answers, great questions, and we'll be back here next week with some more good stem cell information. Thanks a lot.
Thanks.